All right, what's go up? What's up, residents? What's up? What's going on? Uh, so today is May 16th. I think my wife may be coming through here pretty quick, but that's cool, especially with today's theme. So I'm always trying to think of creative ways to bring some value to the residency outside of just your typical case study, reading research articles, things like that. Especially with what we do on the live grain round. So I honestly thought today it would be a little bit interesting to go through my previous week's schedule and maybe even today's and kind of just give you a rundown. Now I can't show you this because obviously just a bunch of patient info, but to kind of give you a rundown of what my week looks like from a professional aspect, maybe a little bit of personal, of how I'm managing time, what some of the cases look like the jump around of different skills, and just kind of show time management, efficiency, what we're working on in the clinic, what kind of a day looks like, because I think that's, is especially if you're going to run your own practice or, even if you're going to be a contractor within somebody else's practice, understanding how the day flows. And if I had to toot my own horn on one thing, it would be time management. I feel like I do a pretty good job about time management. So let's just kind of go. So our schedule in the office, hour wise, is Mondays and Thursdays, 12 to 7 p.m. Tuesday, Wednesday, Friday, the office is 7 to 2 p.m. I'm 8 to 2 p.m. And on Wednesdays, I don't come in until 10 because I have to take Maddox to school. You'd be like, well, those are super weird hours. Yes, they are. The reason we moved to the schedule was when we first opened, we were 8 to 6 p.m. with a take lunch whenever you can. What we found out was that we had a lot of people that migrate towards early mornings and late in the evenings, especially where our location is based on work and school. So we thought it was advantageous to us to not be in the office all day, especially for staff. When you have hourly staff, which is the time our only employee, which still is our only employee that's salary. So it really didn't matter, but we didn't want to work her into overtime and things like that. So we moved to this schedule because now we're in the office 37 to 38 hours a week. On paper, I'm in here a little less, and depending on, I'm in here more than that, working on stuff, seeing patients 37 to 38 hours a week if we're fully booked. And we actually saw the same amount of people, if not more. So again, time management from the schedule perspective. So let's walk through this. So Monday, first patient I saw was a reactivation. So our reacts are either 30 to 40 minutes. This was she's a runner that's dealing with low back pain. It's kind of changed sides now. So now we're talking about what I thought it was before, either like central disc issue or, maybe some central cord stuff. She's a little bit older than me. So maybe that's not the case, but explaining some of that stuff to her, but honestly didn't change our treatment strategy. So we were jumping right back in because she is a nurse practitioner who's been working as a traveling nurse. And now we jump back in with the same treatment kind of framework because nothing's really changed, even though the radicular symptoms have flipped sides. Next patient is a patient that no chief complaint, really just wants to get in here because he feels like he's stiff, not moving as well as he could. Those can be tough patients, honestly, or they can be really easy because, especially as a new grad, maybe I'm wrong, when somebody comes in as a, hey, make me feel better, get me moving better, you would think that'd be your easiest patient. But if you're really in the mindset, which is made to seem counterintuitive, I think we, especially out of school, we're all hopped up on this, hey, I'm treating function, but I still think you're really treating pain. You're going to find that out when you work with an athlete or somebody like this. It's like, well, no, I want you to treat function. You're like, ooh, okay, I don't have pain as a guide. Like I have to literally change the stuff that I need to change. These are easy now, obviously, at this point in my career, because it's like, okay, thanks, I'll take a million of you. Is this your honestly wellness or maintenance patient? Now, go through a typical exam, top tier SMA, point out some major things that we're working on, whether that's, adjusting DNS. I'll also tell you that most of these people are seeking you out because of adjusting. So if that's not in your treatment plan in some fashion, whether that's to feed them what they want or that's actually what they need, I would just think about both sides of that coin. even though this is a maintenance patient, if that's what we want to call it per se, I always front load these people still with a small trial of care, like 4 visits, because I'm seeing if I can change the thing I want to change first. And then that I always explain, hey, I'm going to set a new baseline with you, and then we're going to move forward from there. And I'll leave that up to them, or I'll say, hey, I'll see you once a month or once a quarter. It's in your, when you need to see me. The next one, honestly, was a repeated patellar dislocation. So she dislocated her patella as a 12-year-old girl, I want to say about 2 months ago. Was doing really well. I was just honestly running across the street one day. Like while she's running, it re-dislocates. Now this is a 9 out of 9 on the Baton hypermobility score. She also has a shallow trochlear groove and a flattened kind of patella. So this is a high risk profile. Her father is dislocated his patella numerous times. So she re-dislocates her patella, and when she falls from dislocating that, fractures her arm in 3 different places. So we're dealing with a couple things there. Next one, Jennifer, not supposed to say names. You guys didn't hear that, but new patient. This was somebody that's had just some chronic neck parascapular pain over the years. I'm actually doing a follow-up with her today. Pretty typical patient complaint. Move forward to, if you've seen my social media posts, my buddy James, our cerebral palsy patient, I've been seeing him now for a few months. Obviously a lot of DNS heavy loaded stuff. Story that I haven't shared with James is he was set up with, maybe we did talk about this, dorsal rhizotomy via his clinicians. Yeah, we did talk about this in grand rounds. And his parents really didn't know what to do. His dad's actually a physician, and they came to me and they said, hey, we want to give you a year to see what we can do without that surgery, because James is now 11. My next one is a volleyball player. She is also about 6, she's 5'10", and she's 12 years old. Volleyball player that was an early dancer, diagnosed on imaging, cam lesion to the left hip, having obviously hip pain, but more so medial knee pain. Probably going to do a case workup on that one. Just, it's an interesting one. Really cool case. Next one's a golfer that I've seen on and off. I think he is now 13 or 14 years old. Repeated offender for extension-based low back pain. We found out a lot of what he was doing in the gym, AKA leg press, things like that. We're driving the bus here, not so much even his golf swing. And then a reactive, honestly, a buddy of mine that's a trail runner that was having a little neck issue. So that's one day. Also, so this is a Monday when I'm shooting this. I came in here today, and you may think I'm crazy, at about 6 a.m. I went across the street and ran on the trails. I came back. We have a shower in here. I shower. I start doing work like this, like me shooting this video, doing a bunch of social media stuff, a ton of projects. Like I use the Notes app on my computer and my phone to keep track of stuff. I used to use Evernote. I don't like it as much anymore because you got to pay for it and it doesn't always link up like it should. I'll be working on some R2P stuff today. It's never ending as a business owner, but also like the creative endeavors. Like this is creative to me, the social media stuff, working on some RX3 things. Like you have to find time for those. That's why I also like these 12 to 7 days. Luckily, Sloan allows me to come in early because that's when I crush it for like 3 to 4 hours and get a lot done. So that's what I was doing this morning. And that's what I was doing last Monday. Move out to Tuesday. Like I said, I come in here 8 a.m. I'm usually not coming in early on Tuesdays. I used to. But now what I do is just kind of stay home and have breakfast and get in here when patients start. Who are my two? So I'm trying to, sometimes you got to jog your memory. My first couple ones, so I had a 11-year-old baseball player that it's not little league or shoulder. Honestly, I would call it a true capsulitis, like pain through the entire shoulder that was catalyzed or precipitated by a throw from he played center field from the outfield, and that's when he just like dropped off. So baseball player with some shoulder pain. Sorry about that. We had a woman that had dealt with shoulder pain for about 4 months. This is a classic MDT case. We put her through Extension internal rotation. She comes in, she's about 80% better because she had limited abduction. She was having, when she came back in, the pain had like kind of set in and like kind of anterior, you know, everybody talks about anterior bicep tendon pain, but like AC joint, and you can see this AC joint is more prominent. So we start working on stabilization, DNS work, actually did an AC joint taping. Then one of the runners I've talked about quite a bit on here is the runner that has had repeated stress fractures. We've showed his case numerous times. We took him out of running for, besides he was in a stress fracture for anterior medial distal tibial stress fracture. So he was in a boot for 6 weeks. We took him out of running for a month, undetermined amount of time, month to 5 weeks, where we're just working on reinstalling new software from a movement standpoint before we get him back into running, because he's trying to go run in college and this is senior year. So I finally just kind of beat him and his parents over the head with, we're not going to make the change to running that we need to unless we take a significant amount of time off. So that's him. React for a runner that she's kind of my age, she's found out she had some degenerative labral stuff. She'd been dealing with hip issues forever, but a cam impingement, cam pincher combo. So she'll kind of get some stuff flaring up every once in a while. And now she's having some kind of almost fibularis longus tendon issues, which if you think about what we may shift with that cam lesion, she really gets in this more supinated position, creates a rigid midfoot so she doesn't have to go through hard internal rotation on her hip. React of a runner that's trying to knock out a half marathon in all 50 states, so she gets banged up every once in a while. I had a reactivation the week prior, and this is a follow-up with a golfer. He is, I think he retired this past year, he's just playing a ton of golf, so he gets kind of beat up. I had a virtual consult with a patient that I used to see here that now lives in Montana. He's starting to train for Ironman, so he's getting a little beat up. Just a tune-up for one of my Spartan race athletes that was going to Fayetteville, was this weekend? I believe this past weekend. So he was heading up there. I may be wrong. Yeah, I think it was Fayetteville. And then if you've seen the Instagram post on the T-spine, scalp T-spine patient, I know this is May 16th when we're shooting this. I had a follow-up visit with her. So then I was done at 1:30 that day. Coming the next day at 10, I have a buddy of mine that's a golf pro. We've been working on low back stuff for a while. It's actually the husband of our health coach. So just low back stuff. And now we're working on hip mobility and control and all sorts of stuff. A guy that's a U.S. Marshal. He's on the U.S. Marshal task force, so he's always chasing people down. Had a pretty bad knee injury that we just kind of determined, or I determined, was more of a subpatellar cartilage irritation after a jiu-jitsu match. And he actually had it on video that he kind of had a hyperextension injury. So we've been working on that. A guy that sadly is a buddy of mine that's a runner. We had to send him out for a kind of an exploratory hip scope because we sent him through the gambit of MRI, obviously treatment with me, full round of steroids. Ended up going and getting lidocaine Marcaine injection in his hip, which didn't change anything. So then we're at this weird crux where I think he has a femoral head cartilage lesion. But the last ortho he saw, looking at the imaging and everything, said, yeah, I think something's going on, but the only way we're going to know is if we scope it, which is the honest truth. So now he is set up with one of the best hip surgeons in Birmingham to do that, which I never like. Yeah. And then my last patient of the day is a yogi that I've worked with 2 times now. Yogi fitness, very fit, and kind of busting her myths on breathing and things like that, as you can imagine, which is kind of rocking her world. Hooked her up to the Core 360 with the ohm track sensor, and it was honestly extremely hard for her to do that. So it was just like mind blowing because she's super fit and she's like, I can't do this. And then I had a virtual meeting with a golfer that I'm coaching out of Arizona. So that's Wednesday. And then Thursday is a 12 to 7 day. So I came in again, I think 8 a.m. or something. Got a ton of work done. Then I had a follow-up with a girl that is my age. So she's a 38-year-old woman that came in. She's been dealing with, she can only lift her shoulder to here, obviously generalized shoulder pain for about 2 months. Interesting note on this case is when she lifts her arm, you can see something that looks like a vein. She thought it was a vein. That's her axillary nerve. This is pure axillary nerve entrapment, with maybe a little bit of cervical spine involvement. Obviously, we ruled out cervical spine classically with an MDT model, but this is where we're using axillary nerve neurodynamics, things like that, and a lot of DNS to offload her shoulder. Yeah, so that's kind of an interesting one. My hip case returned again, the 12-year-old volleyball player. One of my favorite tennis players that is, there's two tennis players that I see. One's in his, I think they're maybe a little bit apart, 50, 60 years old. Two stiffest guys I've ever worked with in my life. This guy comes in, he's having some glute med tendon issues. And when he takes a lateral stab step, he just, I mean, literally it feels like it stabs his hip. I thought it was worse than it was, but we did one treatment. He came back in and he's like, I played the day before his return visit. And he's like, I'm probably 90% better. So that's always a good sign. But then he went and played a tennis tournament this weekend, and I'll see him later this week. So we'll see how that goes. And then a follow up with my patellar dislocation case. And I had a short day this day because of staff and other things I had going on. So Friday, my wellness patient from earlier that week, if you remember the guy that just came in, wants to get moving better, this is where your interaction with people is how you build a practice. He immediately is like, man, I need to get my son in here. So his son came and saw me. His son had been having some generalized low back pain. I did mention that wellness patient. He is 6'5". His son is already 6 foot and he's 12 years old. Seems like we got a lot of tall people in Birmingham. And, run him through the gambit, and he has just continuously kept growing for the past year and a half. So there's a lot of stuff that he's dealing with. He's actually a really good sensory motor, athlete, like has great feedback, very coachable. So we're working on some central control concepts before we do anything else. And like I explained to them, we're going to see what changes on all of this stiffness and mobility stuff that's, appeared from growth spurts over the past year. But we're not going to work specifically. I think we're going to end up working on some left hip, left ankle stuff because he's a quarterback pitcher. So there's some unilateral asymmetry there. But I'm never going to jump in on like, hey, let's pick all this stuff apart until we work centrally, control things better, see what kind of falls by the wayside. Follow up with a patient that's honestly a non-responder. This is, in my mind, it's interesting too because she's a clinical psychologist and kind of has herself wrapped up in pain and issues and always comes in with a written out list of stuff. And she's super nice, but it's tough. So we had to kind of be like, hey, I think you need to go hit the challenge button a little bit harder and see how your body responds and see if you actually do get worse in certain areas or if you get better overall. And then my last visit of that day, again, some days are short because I have a lot of meetings. I'm doing other stuff besides seeing patients now. My last visit was actually a virtual consult with a guy that used to live here that now lives in Colorado. Let's just say this is probably the wealthiest client I've ever worked with in my life, and he's younger than me, which is surprising. And he will do just about anything for his health. So we're working on like optimizing health. Like this guy's worked with Ben Greenfield and all this stuff. So that's an interesting and fun one to me because it's not treat my injury. It's like make me better. And then I was out for a meeting there to work on our new office actually. So that was last week. You can see, I mean, in everything in between, me meeting with the landlord next door to work on our new office to, stuff that I'm always working on. And then I jump forward to today. My first patient is a pure maintenance. She comes in, I think, once every 2 months. Another one is a guy that pops in. He drives like 2 hours away, so he pops in every once in a while. Who knows what's going to go on with him? He beats himself up. He's a big whitewater kayaker. A follow-up of a patient that I've seen for a long time that I actually sent in for a shoulder surgery. They ended up doing a bicep tenonesis and a chromolysis. So she did post-op PT with the PT that's in her office. I saw her last week for her first like post-op PT, kind of post-op PT. I have a reeval with, honestly, I can't remember who this is. So we've switched over to Jane. So a lot of people's files are still in ChiroTouch. So I'll have to go look. I have a new patient. Believe it or not, and I'm assuming that their paperwork's right, it says that this is a 6'5", 280-pound female. And interesting note, you can put notes when you make an online appointment in Jane. In her appointment, additional info note says fun ? I don't know what the hell I'm getting into there. Follow up with my 12-year-old hip patient, follow up with my generalized neck complaint. I'm seeing this one is, I'm going to be honest, not fun, but it's a 13-month-old girl that had has torticollis. It was pretty severe. So she did 2 times a week for 8 months of PT where they were just trying to stretch her neck out and all that stuff. She had some success, but she's also a baby. Like anything will change a baby. So now she is shell shocked to treatment. So she absolutely loses her shit when she comes in here to see me. So like, I feel like I need a stiff drink after that one every time. Another kind of maintenance follow-up. And then I have a track athlete, 13-year-old track athlete that has broken every record, every middle school record for the 800 and 400 in the state of Alabama this year. So the fastest girl in the state for her age, and then ran up in state for high school and did fairly well. Bilateral shin splint case. I haven't seen her for 2 weeks because I wanted her to take a full break from everything after state and not see me, not run anything. And then we'll just kind of see how it's everything pans out. So that is, and again, I was in here this morning doing what I said. So that's kind of, I hope this was valuable because that's a breakdown of like, what am I doing in a week? You can see how varied things are across the skill set, which obviously, it's going to vary, but maybe not to that degree. And then like, I like building in these, when COVID hit, having the ability to do virtual consults because I already had a presence online was absolutely huge. I don't do near as many as I used to, but there for a couple months after COVID, like first hit, I had like probably 2 a day. It's a good income source. Can be a challenge of how you assess and do things. But if you ever want more information on how I do those, we can do a talk on that. Last note before I jump off here, and I talked about this on the last Grand Rounds, I've been toying around a lot on, the future of the residency. This is where I think it's going to go. And we'll talk about this on the next Grand Rounds, which let me pull this up so I can say this. So this again, today is May 16th. The next Grand Round is next Thursday, May 26th. It may be the last Grand Rounds ever as the residency exists now. So here's what I think is going to happen. We can talk about this here because you're paying to hear this. So this is kind of behind closed doors. R2P, we're building out courses for R2P, much like MPI, but I think this is a long time coming that we need to be able to teach people how to treat with an active integrative model. So I'm helping build those. I'll be teaching those along with some other of the board members with R2P. But a lot of what I would want to be giving to people in the residency will go into the R2P curriculum. The other thing is R2P is rolling out with a membership. I would like to see in that membership that a lot of what I'm doing right now, whether that's business coaching, like the things that we did with Kyler Brown, research articles, case studies, those are just going to be in or behind the paywall of the membership for R2P. And then what I want to do is I'll probably continue, whether it's through R2P on my own, to just do a once a month, call to Grand Rounds if you want, where you just pay to show up. Maybe it's $4.99, and you just drop that, a little PayPal thing if you want to come to that meeting or whatever it is. The only reason I do that is I usually block out my schedule on Thursdays, right at 6 p.m. or 5:30 sometimes. I have enough time. So if I'm going to block out time, I have to recuperate that because that's just the way business works. So that's why I do that little paywall, but I'll get rid of the paid membership monthly thing. So you can all go be R2P members because there's going to be so much more value there with the discounts that you're going to get on these seminars. It's very exciting to me. But that's what's going to happen. So that may be the last Grand Rounds on May 26th because we had a meeting this past weekend, myself, Jeff Barron, and Kyle Utley, and we're starting to build the coursework, and we're already actually booking a course in Coeur d'Alene for Q1 next year. So exciting news there. I hope you guys got something out of this video, and hopefully I will see everybody May 26th. I'll be putting out a post about maybe it being the last one so we can all get together and have a beer and talk about some stuff. Also, if you do listen to this, let me know if you have any ideas on what you'd like to hear about. See y'all.